Hi everyone, today we're going to talk about abdominal aortic aneurysms, or AAAs. A AAA is a dilation of the abdominal aorta, including all three layers, greater than 3 centimeters. High-yield history and physical exam for a AAA is important. For tests, the stereotypical patient will most likely be an older male over the age of 60 with a history of hypertension and smoking. But in real life, it's important to maintain a high clinical suspicion in all patients who have abdominal pain, back pain, flank pain, or groin pain. The classic triad for a AAA is abdominal pain, pulsatile mass, and hypotension or syncope, which appears in approximately 50% of ruptured AAAs. The pain location can be abdominal, back, flank, or groin. It's important to know that the pain can radiate to these areas and can often mimic other presentations. On physical exam, assessing for pulsatile mass, flank ecchymoses, and hypotension is really important because these can be signs for both AAA and ruptured AAA indicating hemorrhage into the abdomen. A full pulse exam, including femoral pulses, has pretty low sensitivity, but performing this and an extremity exam for ischemia can often be important. The differential diagnosis for a AAA is pretty broad because it involves the abdomen. The picture at the right indicates a good way of organizing all of your abdominal complaints, but it's important to note that these things often don't follow the textbook. They can present in different quadrants and different locations with different radiation patterns. So it's important to keep a broad differential. The most common things AAAs mimic are renal colic, back strain, cholecystitis, pancreatitis, gastritis and gastroenteritis, GI bleeds, diverticulitis, and UTIs. When creating your diagnostic approach to these conditions, it's important to remember that your labs and imaging workup should pretty well fit your differential diagnosis. So labs for this should focus on ruling out all other causes of abdominal pain, flank pain, back pain, or groin pain. So we'll want to get things like a lipase to rule out pancreatitis, a UA to rule out the UTI we had on the list, etc. The important one here is type and screen, because if they do have a AAA, they'll likely be needing blood, and lots of it. For imaging, ultrasound is almost 100% sensitive and specific for unruptured AAA. It does, however, have a limited ability to detect rupture, and you cannot visualize a retroperitoneal hematoma. Also of note, you have to be able to visualize the whole aorta when you're performing ultrasound, and if you don't, the test is indeterminate, which does not mean the test is negative. Abdominal CTA is good because you're able to visualize rupture and guide surgery, but the patient must be stable enough to go to the CT scanner. This image demonstrates an ultrasound of a AAA. The red circle demonstrates the outside layer of the aorta. In blue, the true lumen of the aorta is labeled. The space in between is actually thrombus. This is a good image because it demonstrates how you should actually measure a AAA. If you were to only measure the true lumen, you would improperly rule out AAA with ultrasound, but going from the outside lumen allows you to confirm this diagnosis. Management of this patient is important because this is a true emergency. You're going to want to tell the surgical team as soon as possible because their disposition is likely going to be from the OR and then to the SICU. Next thing you'll want to do is activate mass transfusion protocol, especially if your patient has a known AAA and is unstable. You should also get 2 large bore IVs. You're going to want to get 18 gauges or bigger, but in this situation, we'll take anything. The best IV that a patient can have is the one that's in the vein. Blood pressure management with permissive hypotension is also important. You're going to want a goal systolic of about 90 and a goal MAP of between 60 and 65. At this point, if you just have some free time, there's definitely a benefit to having an ART line in so you can get better blood pressure monitoring, but this isn't necessarily a priority. Finally, you should try not to induct these patients unless you absolutely have to, because it will definitely worsen hypotension and drop sympathetic tone, and you really don't want to send these patients into PEA arrest. To wrap up our discussion about AAAs, we'll go over some fast facts. AAAs are a dilation of the aorta greater than 3 centimeters. A AAA is a diagnosis that requires a high degree of suspicion in patients with back, flank, or abdominal pain. Intraperitoneal ruptures of AAAs are almost always fatal, but some retroperitoneal ruptures will be temporarily contained, so the patient might not look that bad. It's important to still activate your surgical team and take this very seriously. Also important is that while you are doing all the things we talked about in the management section, you can also be getting your history and physical exam during this time, so things can move pretty quickly. These are the resources I used to make this presentation, and if you want to learn more about AAAs, I think these are a great place to start. Thanks everyone for listening.